Good morning, one and all. Today, topic of discussion will be sexual dysfunction. I'm Dr. Agila, Assistant Professor, Department of Psychiatry, Sri Lakshmanarayana Institute of Medical Science, Puducherry, Bharat Institute of Higher Education and Research. So, today we'll be discussing regarding the entire etiopathogenesis, normality, and other uh, disorders, like everything regarding sexual dysfunction. Now, these are the historical developments in sexology. That is, the first dominant personality who describes central importance of sexuality into human existence will be our very own Sigmund Freud. Um, then we have the psychoanalytical methods, that is, sexuality as primary cause motivation. He names something as libido, and also this deviations and aberrations in child psychosexual development causes the future um, neurosis like symptoms. And although his work was criticized, states more than one element apart from sexuality only has pivotal roles in development. Still, psychoanalysis remains a major form of diagnosis for psychological illness. Now, this is psychosexual stages of development of childhood. That is the oral phase, which starts from 0 to 18 months, and then the anal phase from 18 to 5 years of age. That is 3 years of age, and then there is the phallic phase, which is the 3 to 5, and then the latent phase, the 5 to 9, and then from 9 onwards until puberty, 9 to 11 will be the genital phase. So here we have the oral phase where there's mouth sucking and swallowing. This is where the ego develops. The anal phase where the anus withholding, that is anal sadistic and hedonistic pleasures. So now phallic phase where the penis or clitoris masturbation and penis envy, all these things develop, and there's where the Oedipus complex and Electra complex, and then we have the superego which develops there. And then we have the latent phase where little or no sexual, this is like an asexual phase, and then the genital, this is the actual differentiation of uh, the gender and gender identity issues, everything pops up in the genital phase. So now Eric Erikson also goes to some extent regarding the development. He has given all these stages for 8 years of life. First 8 years, second 8 years, third 8 years of life. Now we have crisis, that is the trust versus mistrust, autonomy versus doubt in the second year, and then the third to five we have initiative versus guilt. Sixth year to puberty we have the industry, a sense of industry versus inferiority, adolescence identity versus confusion, and early adulthood intimacy versus isolation, generativity versus self-absorption, and aging years, that will be integrity versus despair. So here we have Malinowski postulates the sociological and cultural dimensions of sexuality. Henry Miller made philosophical statements about sexuality. Gestalt psychologists thought mind as a whole component, like encompassing all aspects of development through complete interactions between body, mind, social determinants. So, what is sexuality? It encompasses sex, gender identity issues, roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. Sexuality is experienced and expressed in thoughts, fantasies, desires, beliefs, and attitudes, and values, and behaviors, practiced roles, and relationships. So, what is this health? Now, a state of physical, emotional, mental, and social well being, um, where in relation to sexuality, it is merely not the absence of disease function uh, um, or infirmity. Sexual health requires a positive and respectful approach to sexuality, sexual relationships, as well as the possibility of having pleasurable and safe sexual experience free of coercion and discrimination and violence. Now, reproductive cell cycle theory of aging. This is chemical reactions like HPG axis mainly. Hormone normally promote the growth and development of the organism, and it's directed by the HPA axis. So when the HPG axis becomes unbalanced, cellular growth and development is dysregulated, cell death and dysfunction occurs. Now, in infancy, like we have studied, we can see USG studies provide that there are some reflex erections, even in children, like in baby boys, several months before birth. And there are newborn baby boys having erections in the first few minutes after birth, even before umbilical cord is cut. Similarly, newborn baby girls have vaginal lubrications and clitoral erections in the first 24 hours. 3 to 4 months genital stimulation accompanied by smiling and cooing. Sensuous closeness to parents through holding, clinging, cuddling are the forms of phase of infantile sexuality. The child who is deprived of warm, close bonding during infancy may later find difficulty in intimate relationship or being comfortable with their sexuality. 2 to 3 years, there is solitary, in pair, or group sexual play, and the parent gives negative messages that if dirty children take literal meaning of dirtiness to paving to later life sexual difficulties. In 4 years, as vague and magical notations about childbirth. 5 years fascinated with learning words about parts and jokes about genital functions, and 6 to 7 years have clear anatomical differences, becoming modest to show body to others. Sex plays in two-thirds occurs, also involving siblings. So 8 to 9 years has knowledge of erotic element in sex plays, sexual fantasies, falling in love occurs, and learn to relate others, leading to development of adult psychosexual adjustment. Up to 12, it is few also have the sexual activities, including animal or objects, sometimes oral or animal. Why we do not remember, Ernst Borman said, puberty characterized by a special amnesia, blocked memories about prior sexual experiences. And sexuality in puberty is like sexual fantasies, dreams. Fantasy add pleasure of sexual activity and substitute a real but unavailable experience, induce arousal or orgasm, and provide form of mental rehearsal for later life, real sexual experience, and provide a safe, controlled, unembarrassing means of sexual experimentation. Patterns of sexual behavior, masturbation, petting, intercourse, homosexuality. Early adulthood, 20 to 40 years of sexuality, more driven by internal needs to become more sexually knowledgeable and has more sexual opportunities. Conflicts may arise due to attitude of sexual guilt carried over from earlier age, coming out for homosexuals associated with marked dysfunction. Pregnancy, sexual desire may vary between individuals' first trimester, nausea, vomiting, and fatigue and aversion. Second trimester, desire and physical response in 80%. Third trimester, drop in frequency. In married couple, integration between burden of needs, responsibility may fail, leading to sexual dysfunction. Extramarital affairs may sprout, and divorce may arise due to sexual dysfunction. Middle adulthood, we have a midlife crisis where the male is more like over the hill position once start about questioning the capabilities. Female are like who remain mostly children, mothers mostly attached to the children, attain independence, emptiness syndrome. However, leading children gives a couple of chances to their own interactions and opportunities to clear more relaxed subjects. And sexual burnout stems from tedium, satiation with same sexual routines, and marked by a sense of depletion, emotional emptiness, and negative self-concept. So late will be like sexual organ atrophy, diminished testosterone levels, delay in attaining erection of poor quality, longer delay in achieving and maintaining erection, decline in intensity of orgasm, and radius. Now, biological constrictions in female, loss of elasticity in breast tissue, cervix and uterus shrunk, and walls of the vaginal canal atrophy, vaginal length and width decrease, decrease in vaginal lubrication, sex steroid starvation. Cause of sexual dysfunction in late adulthood is basically due to biological changes of aging, negative cultural expectation, medical or surgical problem, effect of drugs, mental illness, and availability of partners. So, physiology of coitus, we have the four stages, that is the excitement, plateau, orgasm, and resolution. Now, if you can see the male pattern, it is like there is a multiple um, peaks, and there is this B pattern where there is like it's just going more of a plateau phase and then it comes down. And it's not multiple for males, it's actually multiple for female, that is orgasms. It's just two big peaks, and then there is a resolution phase. Now, for female, if you see there are multiple orgasms, like they are capable of going for multiple orgasms, but for male, it's quite restricted, and they also achieve the plateau phase, and then it slowly comes down. So this is a human sexual response cycle, and if you see the refractory phase, like between one cycle and the other, now that is like longer for males and shorter for females. So sexual dysfunction, that is, we are going to discuss regarding the male sexual dysfunction in female. Male is erectile dysfunction or impotence, premature ejaculation, ejaculatory incompetence, and female sexual dysfunction will be vaginismus, anorgasmia, and dyspareunia. So now this is erectile dysfunction. Here we have the ICD 10 criteria which we'll be discussing. This inability to have or maintain the erection that is firm enough for coitus. Now, primary ED is never been able to have an intercourse. Secondary is have succeeded to have an intercourse before dysfunction began. ED can occur at any age. Total absence of erection is infrequent. Partial erection that weak for vaginal insertions. Firm erections that quickly disappear if intercourse is attempted. ED with normal erections and changed partner, changed sexual pattern that is intercourse. Now, isolated episodes of having no erections or losing an erection at an inappropriate time are so common that the universal occurrence that are the universal occurrence in men. So, Master and Johnson classified a man as secondarily important only if erection problems occurred in at least 25% of sexual intercourse. Isolated episodes may be due to fatigue, distraction, inebriation, acute illness, transient anxiety, and lack of privacy. Now, fears of sexual performance, will I loosen my erection? Will I satisfy my partner? Are likely to dampen sexual arousal and cause a loss of erection. The stronger and more insistent such fears become, the man will experience an actual inability to get and keep an erection. On long-term basis, it will lead to avoidance of sex, loss of self-esteem, anxiety to overcome ED, and sex becomes a problem. Now, this is a cycle of erectile dysfunction, performance fear, spectator role, distraction, loss of erection, and again there is erectile dysfunction. Now, etiology of ED, where we have the anatomical cause, that is congenital deformities, testicular fibrosis, cardiorespiratory causes, coronary, pulmonary, MI, and pulmonary insufficiency, drugs like alcohol, beta blockers, antidepressants, anti-androgens, nicotine, narcotics, barbiturates, imidine, clonidine, endocrine causes, diabetes, age-related decline in testosterone, hyperprolactinemia, genitourinary causes, phimosis, priapism, hematological causes, sickle cell anemia, acute and chronic leukemia, infectious causes, elephantiasis, urethritis, mumps, genital TB, neurological causes, cerebral palsy, spinal cord transection or tumors, multiple sclerosis, PID, vascular causes will be thrombotic obstruction, aneurysm, arthritis, and miscellaneous will be CRF, Developmental factors we have these are the psychogenic ED, psychogenic erectile dysfunction, where maternal or paternal dominance, conflicted parent-child relationship, severe negative family attitude towards sex, child abuse, traumatic coital experience, gender identity conflict, and cognition factors, acceptance of cultural myths, paraphilia. Affective factors are anxiety, performance anxiety, guilt, depression, poor self-esteem, hypochondria, fear of VD. And interpersonal factors is poor communication, hostility towards a partner, lack of physical attraction. Now here we have a very good flow chart. That is the cause, that is eliminates the causes, like there could be drug, and if it is not improved, then it's likely because of the pathology we have to always look for anatomical first. Then we have to go for the psychogenic and therefore for psychotherapy. And then we have the uh, if it doesn't improve, most probably it's organic, and then we have to go for LH and prolactin levels over here, and then LH and prolactin levels, endocrine and HPG axis. Then LH increase prolactin hormone, testosterone, and improve. If it does not improve, then refer to a urologist, NPG test. Of course, if it does not improve, then again organic impotence etiology, measure testosterone level low this way and normal this way, further evaluation. Now here we have the refer to urologist NPT test, abnormal PBI, vascular testing, neurological testing, vascular or neurological ED, consider surgery processes or revascularization. Now, if it is improved, then we have to go for psychogenic, so psychotherapy improved. If it is not improved, then we have to go for this one, this further evaluation, and then this is a approach. In the treatment of ED, we have this penile process, and the penile process is something non-inflatable, semi-rigid device, inflatable. So two types, non-inflatable and inflatable. And drug treatment, yohimbine, of course, sildenafil comes first, adalafil comes second, and morphine, sublingual, intracaversonal injection of vasoactive drugs, intraurethral insertion of prostaglandin, use of vasoactive cream, and apomorphine sublingual tablets. Now, treatment of psychogenic ED, sex therapy is indicated if counseling attempts have not reversed the dysfunction. Now, sex therapy ideally includes both the impotent man and the partner, since therapeutic cooperation of the wife appears determinant of the outcome. So, patterns go like this. It is psychotherapy. It is not useful to blame one's partner or oneself for the occurrence of dysfunction. There is no such thing as an uninvolved partner and sexual difficulties. Sexual dysfunctions are common problems and do not usually associate with psychopathology always. It is not always possible to be certain of the precise origin of sexual dysfunction, but treatment can be frequently proceeded with successfully even though knowledge is lacking. In general, cultural stereotypes about how men and women should behave or function sexually are misleading and counterproductive. Now, sex is not something a man does to a woman or for a woman. Something a man and a woman do together. Sex does not mean only intercourse apart from procreative purpose. Sex can be a form of interpersonal communication at a high intimate level, and using the past feelings or behaviors to predict the present is not likely helpful. Developing awareness of one's feeling and ability to communicate feelings and needs of partners in the stage of sexual interaction, assuming responsibility for oneself rather than delegating this responsibility to one's partner is often effective means of improving the sexual relationship. Now, premature ejaculation, although premature ejaculation is a common sexual dysfunction, there are no precise definition basically. So, Master and Johnson do not consider it as a problem unless it occurs 50% or more of the times coitus is attempted. If the man's rapid ejaculation limits his partner's ability to reach high level of sexual arousal or orgasm, then a problematic situation do exist. Male who persistently ejaculates unintentionally during non-coital sexual play or while trying to enter his partner has a greater problem. So etiology we have with this ejaculation is a reflex phenomenon neurologically and possible endocrine pathways. Common historical causes are first coital experiences under circumstances of fear or being encouragement of for rapid ejaculation from prostitute. In effect, the man becomes conditioned to fast ejaculation and subsequent sexual encounters. He was often unable to alter the pattern that has been established. Thus, primarily, it is a psychophysiologic disorder. So, this is about premature ejaculation. All the precise neurophysiologic events that trigger ejaculation in male are not known. A program of reconditioning the ejaculatory reflex response can be easily undertaken. That is couple therapy, discuss physiology of ejaculation, squeeze technique. When genital touching is begun, the woman puts her thumb on the frenulum of the penis and places her first and second fingers just above and below the coronal ridge on the opposite side of the penis. A firm grasping pressure is applied for 4 seconds and then abruptly released. Pressure is given from the back to front, never from the side to side, using pads of fingers and thumbs, and avoid pinching of the penis or scratching with the nails. For unknown reasons, the squeeze technique reduces the urgency to ejaculate and it may cause temporary or partial loss of erection. So it should not be used at the moment of ejaculatory inevitability, can be used where the penis is erect or flaccid. When couple begins having intercourse, the woman is asked to squeeze the 3 to 6 times before attempting insertion. Once the penis is fully inside of her, she should hold still for 15 to 30 seconds with neither partner thrusting and then move off the penis and apply squeeze again and reinsert. This time slowly thrusting pattern can begin. Now once the man improves his ejaculatory control, both partners are taught the basilar squeeze so that the intercourse need not be interrupted by repeated dismounting to apply squeeze. Kegel exercise is to improve the muscle tone by strengthening the pubococcygeus and muscle of the pelvic can be aid in reducing premature ejaculation. Drugs that increase serotonin signaling in the brain slow ejaculation and have been used successfully to treat PE. These include selective serotonin reuptake inhibitors, that is paroxetine and clomiprazole. Now, ejaculatory incompetence is something that infrequent, generally below the age of 35. Primary, never been able to ejaculate in vagina. Secondary, men who have lost the ability to ejaculate and intravaginally, and or who do so infrequently after the prior history of normal coital ejaculation. And 15% the ejaculation occurred only in nocturnal emissions. It may be partner relative or it may be uh, incompetence may be a source of pleasure as it permits long. Um, Women may feel their partner do not find her attractive or withholding of orgasm is a sign of selfishness. In procreation and sex, it can be frustrating. Only in 5% drug use and neurological disorders can be attributed. Now, here we have, like you can see, ejaculatory incompetence theory is something where the ejaculating by masturbation while alone, ejaculating by masturbation in presence of his partner, ejaculating by manual stimulation received from his partner, having the partner stimulate the penis vigorously to the point of ejaculatory inevitability, and then quickly inserting in vagina. With ejaculating once or twice intravaginally, fears or inhibitions about this act disappear completely. Where sequence has not worked, it may It may be helpful to have the man ejaculate externally onto a woman's genitalia after he becomes used to seeing the semen in gentle contact with his partner. Intravaginal ejaculation may occur more easily. Now, the retarded, or it is also known as delayed ejaculation, seen in 2 to 3 times common more than ejaculatory incompetence. It may be source of sexual enjoyment, but prolonged periods of coital thrusting and required to bring about the ejaculation are uncomfortable both physically and mentally. Women may become resentful, however, both ejaculatory incompetence and retarded ejaculation may be isolated and cause fatigue and tension and illness, and too much sex in short time affects of alcohol, other drugs, or when men do not like partner, but he feels it's expected from him. And sexual dysfunction and rape of these erectile dysfunction occurred in 27 men, like 101 rapists were studied, and PE occurred in 5 men. EI was seen in 26 cases. So here we have rape is not primarily an act of sexual desire. 58% of the rapists in the study were sexually dysfunctional. So what is the point here basically? Absence of semen in rape victim is not required. So vaginismus is a condition in which the muscles around the outer third of the vagina. Now we have moved on to the female sexual dysfunction, where we have vaginismus as one of them. Outer third of vagina has involuntary spasm in response to attempts at vaginal penetration. Less than 10% of female dysfunction cases occurs at any ages and severity varies. Less severe but considerable distressing is pelvic pain. In milder form, women may have an intercourse but only with some discomfort. Most women do have a little or no difficulty with arousal. Vaginal lubrication occurs normally. Non-coital play may be pleasurable. Satisfying orgasms may be unaffected. Affects male partner thinks he's hurting her, becomes more passive. ED may develop. Procreative sex is not possible. Causes mainly psychosocial problem. However, any of the organic cause of dyspareunia can condition a woman into vaginismus. A natural protective reflex, even when underlying organic problems treated, vaginismus may remain, particularly when it has been present for a longer time. Treatment: explain the nature of the involuntary reflex muscle spasm to the couple, demonstrating the reflex in carefully conducted pelvic examination with male partner. Women urged to watch by use of mirror. Techniques for relaxing muscles around vagina: first deliberate tightening and simply let go. Various sized plastic dilators are used first. Physician inserts the smallest dilator. Woman is shown how to insert dilator herself and using plenty of sterile lubricating jelly, and advised to practice this at home several times a day, keeping the dilators in place for 10 to 15 minutes at a time. Most women can use largest dilator by the end of 5 to 6 days, that is of erect penis thickness. Now here we have anorgasmia. Primary anorgasmia, women who never had an orgasm. Secondary will be who were regularly orgasmic at one time but no longer are. Situational anorgasmia, women have had orgasms on one or more occasions, but only under certain circumstances. May orgasmic duration, masturbation, but not when stimulated by partner. Coital anorgasmia, women who may have orgasm in other than the coital act. Random anorgasmia, women who have experienced orgasms in different types of sexual activity, but only on an infrequent basis. So some anorgasmic women get a little pressure out of sex and see it as an obligation of marriage or a means of maintaining relationship. Other anorgasmic women find that sex is stimulating and satisfying. Not having orgasm can create fears of performance that propel women to spectator role. dampening her overall sexual responsiveness. Anorgasmia also leads to less self-esteem, depression, and sense of futility. The male partner may feel threatened as they may assume that it is their responsibility to make the partner orgasm. And treatment of anorgasmia depend greatly upon the nature of dysfunction. A woman with poor body image may be helped to find various ways of regarding her body image more positively. A woman who is distracted from high levels of arousal by disturbing fantasies might be thought blocking, and women who cannot go beyond plateau may be encouraged to experiment with fantasies, and dealing with performance issues with partners to curtail spectator role, reducing inhibitions that limit the women's orgasm arousal, and masturbation or stimulation by partner, bridging technique that is stimulation of clitoris. Now, other approaches to sex therapy are stop and start method by James Simon, and we have manual penile stimulation stopped as the man reaches for ejaculation rapidly to the sense of ejaculatory urgency disappears. Stimulation then begins again, and behavioral therapy. Now, what is andropause? Now, andropause means like how we have menopause, they have andropause, male stoppage, that is the cessation of sexual drive in male. So here we have climacteric androchlisis. These are the other names. Androgen declining in the age male and partial androgen deficiency in aging male, PADM, and then aging male syndrome, AMS late, and onset hypogonadism, a syndrome in which the changes accompanying aging are associated with the signs and symptoms of androgen deficiency in older male. Signs and symptoms are accompanied by a low serum testosterone level. Testosterone levels with age. Testosterone free T index, like you can see, like how much it is uh, going. So here we have hypogonadism in aging men. Like you can see free T index, that is free testosterone, and the actual testosterone is very less. So here we have the total testosterone less than 11.3 millimoles, and total testosterone, that is free T index less than 0.153 nanomoles. Signs and symptoms, of course, we know erectile dysfunction, reduced erectile quality, diminished nocturnal erections, decreased vigor, easily fatigue, poor exercise, diminished strength and muscle mass, decreased libido, sexual activities decreased, limited quality of orgasm, reduced in ejaculate strength, reduced ejaculate volume, and here we have psychological mood changes, poor concentration, loss of motivation, reduced initiative, memory impairment, and anxiety, depression. Diagnosis of late onset will be like if total T is more than late onset hypogonadism will be if total T is less than 200 nanogram per deciliter, hypogonadism is present regardless of age. If total T is 200 to 400, obtain free T. Once T deficiency is established, obtain LH and prolactin. So medications and low T, that is decreased Leydig cell production will be corticosteroids, ethanol, and ketoconazole. Bind to androgen receptor will be spironolactone and cimetidine. Decreased gonadotropin secretion will be corticosteroids, ethanol, estrogen, progestins. Decreased conversion of T to TTH is finasteride. Now, available T preparations, testosterone preparations are oral preparation, transdermal testosterone scrotal patch, sublingual testosterone, local application of DHT as andractin gel, injection testosterone esters. These include testosterone enanthate and testosterone cypionate, given intramuscular injections every 10 to 14 days. Long-acting testosterone as testosterone busylate given once in 4 months. Testosterone implants are now available, which once injected remain effective for up to 6 months. Now, what is menopause? Menopause is similar for women, where permanent cessation of menstruation resulting from loss of ovarian follicular activity. Perimenopause is a period where there is endocrinological, biological, clinical features of approaching menopause commence, and at least first year after the menopause. menopause. Postmenopause dates from the menopause, although it cannot be determined until after a period of 12 months of spontaneous amenorrhea has been observed. So this is how it happens. You can see the FSH levels going up and LH levels coming down, estradiol going down, progesterone going down, fertility definitely going down, hot flushes becoming more, and dry vagina becoming more, and psychological symptoms more in the premenopausal, that is in the perimenopausal, osteoporosis ever increasing, and usual age is 45 to 50, being 47 being mean, premature is below 40, late menopause is beyond 40, delayed menopause due to good health and better nutrition, also seen in women and uterine fibroids, also in women with high risk of endometrial cancer. Menopausal age is directly associated with smoking and genetic disposition, and smoking induces premature menopause. So basically, it's the ovulation fails, no corpus luteum, ovarian activity declines, and no progesterone is secreted, and Brachyian follicle fails to develop, estrogenic activity decreases, endometrial atrophy leading to amenorrhea, increased secretion of FSH and LH by anterior pituitary, surgical menopause or radiation, chemotherapy, alkylating agents, smoking, caffeine, alcohol, and drugs such as GnRH, heparin, corticosteroids, and clomiphene. So estrogen, progesterone, you can see the reduction, that is 35% reduction from age 35 to 50, 75% reduction from the age 35 to 50. At menopause, there is a relatively high estrogen compared to progesterone. Now, symptoms we already read. Now, treatment will be counseling, mild tranquilizers, and HRT. HRT we can see for women with climacteric symptoms, vasomotor symptoms, urinary symptoms, sexual dysfunction, established osteoporosis, premature menopause, family history of osteoporosis, poor diet, excess alcohol, CVD, Alzheimer's disease, and colonic cancer, corticosteroid and other medications, low plasma estradiol, premature menopause, ovarian failure occurring in 2 SD in a year before, that is 2 standard deviation in a year before the mean menopausal age in the population. Secondary amenorrhea for at least 3 months with raised FSH or LH and low E2 levels in women under 40 years of age, increased by 1%, and be 30 years, that is 1 is to 1000, 35, 1 is to 250, and 40 years, 1%. Now, late menopause is something that occurs in women with fibroid and is seen with women who develop endometrial cancer. Often it is constitutional beyond 52 years. Endometrial biopsy is required to rule out endometrial pathology. These are my references, and thank you very much.